హాయ్ ఫోక్స్, వెల్కమ్ టు మై ఛానల్ ది యావరేజ్ డర్మాడాక్. ఇక మొదలెడదామా? Before going to know about methotrexate, let us see something about the man who discovered the drug methotrexate, Dr. Ella Pragada Subbarao. He was born in Bhimavaram in Andhra Pradesh, my own state. Both of his brothers died of tropical flu. His mother suffered filariasis. Because of all these effects, he failed 10th twice and passed in his third attempt. He wanted to find out a drug for all those suffering and he wanted other family members to not to get affected the same. So he went on to study MBBS in MMC Medical College, Madras Medical College, and he got LMS certificate, not MBBS certificate, because he supported Gandhi by wearing only Indian dress. So they gave somewhat lesser degree than MBBS, that is licentiate in medicine and surgery. He went on to Harvard University and got diploma in tropical medicine. He discovered ATP as energy source of the cell, folic acid and its antagonist methotrexate. He discovered diethyl carbamazine, played a key role in the discovery of tetracycline. Because of all these discoveries, he was titled as Wizard of Wonder Drugs. On behalf of his name, a fungus was named as Subbaromyces and a spider was named as Tanzania ella pragadei. Now let's discuss about methotrexate. It's a category X drug, so we can't give in pregnancy. Coming to its other names: A-methopterin, 4-amino N10-methyl pteroyl glutamic acid. It is an antimetabolite which is structurally similar to folic acid. It differs from folic acid in only two positions. In 4th position, folic acid contains hydroxyl group, here amino group. In 10th position, in the place of hydrogen, here methyl group will be there. Both methotrexate and folic acid are pteroyl glutamic acids only. Methotrexate formulations. It's available in oral tablets, IV, IM, subcutaneous and topical. When we give tablets to adults, there is no effect with food intake. In children, milk and milk-based products reduces GI absorption of methotrexate. Coming to pharmacology, it reaches peak within 1 hour. It has 50% plasma protein bound. T-half is about 4 to 5 hours. Only 50% of the drug is free to act in our body. It is reduced from the blood in 3 phases. Phase 1, because of distribution to various body parts in 0.75 hours. Phase 2, renal excretion. 95% of the drug is excreted unchanged through renal elimination within 2 to 4 hours. Third phase, 10 to 27 hours. This is because of slow release of methotrexate from the enzyme dihydrofolate reductase. I already told it's distributed well all over the body except the brain because it has poor blood-brain barrier penetration. Through the enzyme follyl polyglutamate synthase in liver, it's converted to its metabolite methotrexate polyglutamate. Both the drug methotrexate and its metabolite methotrexate polyglutamate are active. Coming to mechanism of action, it's a potent competitive inhibitor of the enzyme dihydrofolate reductase. Its natural substrate was folic acid, but methotrexate has higher affinity than folic acid, so methotrexate will go and bind to dihydrofolate reductase and will inhibit the further folate pathway. Here, despite in the presence of folic acid, if you give methotrexate, dihydrofolate reductase will get bound to methotrexate only because of higher affinity. This meme is from famous Telugu movie. If you have free time, go watch. Movie name Venki. Now coming to folic acid pathway. First, in our body, folic acid is converted to its active form tetrahydrofolate through the enzyme dihydrofolate reductase through two-step process by formation of an intermediate dihydrofolate reductase. Here methotrexate inhibits this enzyme and it won't allow further folate pathway. Next, it also inhibits partially thymidylate synthetase and it won't allow thymidylate to form. Ultimately, it leads to inhibition of DNA synthesis. No DNA synthesis will happen in actively dividing cells in the bone marrow, so it has its effect on blood cells. Now, if methotrexate has become overdose and went to toxicity, how we will treat toxicity? Now, methotrexate inhibited dihydrofolate reductase. Tetrahydrofolate is not forming. We have to give tetrahydrofolate bypassing the enzyme dihydrofolate reductase. So directly tetrahydrofolate we can give to treat methotrexate toxicity. What is that? Folinic acid, leucovorin calcium, citroron factor, all these three are same thing, only 15 to 25 mg we will give. Next, we will have to bypass the enzyme thymidylate synthetase by giving thymidine. Thymidine kinase will act on it and produces the end desired product thymidylate to proceed to DNA synthesis. Now, the inhibited DNA synthesis we have to stimulate by giving colony stimulating factors like filgrastim. It's a granulocyte colony stimulating factor. Methotrexate is a weak acid and it gets precipitated in the renal tubules in case of overdose. So we have to overcome that by giving hydration and alkalinization of urine. So it will excrete methotrexate, excess methotrexate from the body. To treat methotrexate toxicity, treatment I told you 4 points. First point, folinic acid. For what purpose? To bypass the enzyme dihydrofolate reductase inhibition. Second, thymidine to bypass thymidylate synthetase. Next, to stimulate the inhibited DNA synthesis, granulocyte colony stimulating factor filgrastim. Next, to eliminate the excess methotrexate, alkalinization and hydration. Higher dose of methotrexate are used for cancer treatment, particularly hematological cancer. Next, our dermatological uses. What mechanism of action will work? Immunomodulatory or immunosuppressive action at low dosages. Maximum dose per week we can give 25 mg per week. How immunosuppressive action occurs? By inhibition of DNA synthesis of immune cells, proliferation and migration of immune cells, primary and secondary antibody response inhibition. All this leads to immunomodulatory or immunosuppressive action. Next, anti-inflammatory action by inhibition of enzyme ICAR transformylase, which leads to accumulation of ICAR and intracellular accumulation of adenosine. Adenosine is anti-inflammatory. A for adenosine, A for anti-inflammatory action. Here ICAR full form amino imidazole carboxyamide ribose 5-phosphate. Anti-fibrotic action. It inhibits collagen by decreasing its production, increasing the degradation of collagen by matrix metalloproteinases, one of which is collagenase. Now it has 3 mechanism of actions. 1. Immunomodulatory. 2. Anti-inflammatory. 3. Anti-fibrotic. Now coming to uses. FDA approved dermatological uses are only 2. Psoriasis, Sézary syndrome. In psoriasis, particularly severe psoriasis and pustular and arthritis, psoriatic arthritis, these two only mainly. For pustular psoriasis, drug of choice is acitretin. It is first line of drug. If systemic retinoids like acitretin is not working, phototherapy is also not working, then as a second line we can give methotrexate in pustular psoriasis. It is also given in erythrodermic psoriasis. Coming to off-label uses, immunobullous diseases like vulgaris, cicatricial pemphigoid, bullous pemphigoid, epidermolysis bullosa acquisita, autoimmune connective tissue diseases like dermatomyositis, SLE, scleroderma, scleroderma, diabeticorum. Scleroderma is nothing but thickening of skin due to fibrosis. Methotrexate has anti-fibrotic action. Localized scleroderma is also known as morphia. Here by the word immune, try to remember these 2 uses, immune, autoimmune, immunobullous diseases. Next, by the word dermatosis, remember these 2, proliferative and neutrophilic. Behçet's pyoderma gangrenosum. PRP, pleva, full form pityriasis rubra pilaris, pityriasis lichenoides et varioliformis acuta. Remember next 3 A's, alopecia, atopic dermatitis, arthritis nodosa, cutaneous polyarthritis nodosa. Coming to miscellaneous off-label uses, sarcoidosis, mycosis fungoides, lymphomatoid papulosis, 2Cs, 2Ks, cutaneous Crohn's, chronic spontaneous urticaria, keloid and keratoacanthoma. By the word OID, we can remember three off-label miscellaneous uses: sarcoid, mycosis fungoid, lymphomatoid, papulosis. Coming to side effects. Hematological. Already DNA suppression, no new blood cells, pancytopenia, most common cause of death. To prevent this, we have to supplement with folic acid 5 mg daily, except on the day of methotrexate. It not only prevents mild hematological side effects, but also prevents GI side effects also. Next, hepatotoxicity in the form of fibrosis, pulmonary toxicity in the form of fibrosis, which is rare. Another rare idiosyncratic life-threatening side effect, acute pneumonitis. GI, nausea, vomiting, abdominal pain, most common nausea. Here, we have to supplement folic acid to prevent these GI side effects. Or we have to reduce dose, we have to give antiemetics like ondansetron. If despite giving folic acid, if diarrhea is happening, like chronic diarrhea, it indicates methotrexate toxicity. Renal dysfunction is due to precipitation in renal tubules in case of overdose. Skin and mucosa, oral ulcers or stomatitis, and rapid ulceration of psoriatic plaque. These two are indications of toxicity. Psoriatic plaque will become rapidly ulcerated. Oral ulcers will develop to form in case of methotrexate toxicity. There is one phenomena called cutaneous recall reaction in the areas of prior irradiation or recent sunburn. If it's because of irradiation, radiation recall. If it is in the area of prior recent sunburn, it is phototoxic recall. By giving methotrexate, already areas prone to irradiation or sunburn prior, these reactions will come again with methotrexate. Others like alopecia, fatigue, headache, if we use chronically, hyperpigmentation will develop. Coming to contraindications. Absolute pregnancy lactation. Already I told it's a category X drug. In pregnancy we can't give lactation, and if already there is a significant thrombocytopenia, leukopenia, anemia, if we give further, they will reduce it. Further it will aggravate this pancytopenia. Now relative contraindication. Hepatotoxins like alcohol, diabetes, hepatitis. If already there, it's a relative contraindication. Now, if there is a mild hematological disease or renal dysfunction, we have to adjust the dose and give. Diabetes mellitus and obesity are also risk factors for hepatitis. Already methotrexate is an immunosuppressive drug. In HIV, they will be already immunosuppressed. In TB patients, because of immunosuppression, TB will reactivate again. Now, couples contemplating for pregnancy, conception, we can't give methotrexate because in men it will cause reversible oligospermia. In females, it's a teratogen. So, both men and women have to wait 3 months after taking the last dose of methotrexate. Coming to drug interactions. What and all drugs will increase methotrexate levels in the serum? What drugs will decrease? First we will see which decreases the methotrexate. Only 3 drugs. Remember in the mnemonic of CAP. Ciprofloxacin, amiodarone, penicillin. If we give CAP, methotrexate serum levels will fall down, reduces. Next, which increases methotrexate levels by displacing it from the plasma protein bound form to increase free methotrexate in the body, leading to increased methotrexate level inside the body, like probenecid, phenytoin, phenothiazine, chloramphenicol, tetracycline. Along with that, some drugs will not allow methotrexate to eliminate through renal exusion. It will increase the dose of drug inside the body. They are NSAIDs, salicylates, sulfonamides. Some drugs have similar action on folate pathway, inhibiting folate pathway, which further leads to hematological side effect if given simultaneously. What are they? Dapsone, sulfonamides, cotrimoxazole. By mistake, if patient takes daily methotrexate, then also hematological side effects are going to aggravate. Initiating therapy. Before initiating therapeutic dose of methotrexate, we have to check baseline CBC, LFT, RFT, screening for HIV, TB, hepatitis B, C, pregnancy test. All these are relative Contraindications: HIV, TB, hepatitis B, hepatitis C, prior hepatic dysfunction. Pregnancy, absolute contraindication for methotrexate. We have to first give a test dose of 2.5 to 5 mg and wait for 5 to 6 days. Then again repeat CBC, LFT, RFT. If they are normal, we have to start with therapeutic dose in the range of 5 to 15 mg per week. Now coming to monitoring during treatment. CBC, LFT, RFT, initial few months we have to monitor quite frequently, 1 to 2 weeks once, and then 1 to 3 months once. After initiation of therapy, chest X-ray has to be taken after 6 months, or if respiratory symptoms develop, immediately we have to take chest X-ray. If in case total leukocyte count falls below 3.5, platelets below 1 lakh, creatinine elevated more than 1.5, liver enzymes twofold increased, all these are indications of methotrexate toxicity. If creatinine clearance is well and good, we can start methotrexate. If it is less than 20, we have to stop methotrexate. If it's in between 20 to 50, we can give by reducing the dosage to half. Now we have to monitor for liver. Methotrexate is a hepatotoxic drug. How we will monitor? Gold standard test is doing percutaneous needle liver biopsy. When we will do, if cumulative dose is 3.5 to 4 gram in normal and 1 to 1.5 gram in high risk group. High risk means already they have hepatic pathology, alcoholics, diabetes mellitus, obesity. First baseline liver biopsy at 2 to 6 months of initiation therapy, and after every addition of 1.5 gram of cumulative dose. If we do this many times, invasive test, it's unnecessary. So they found some non-invasive tests like USG, FibroScan, procollagen 3, serum amino terminal peptide of procollagen 3. Here the drawback is it will identify fibrosis while happening in the body, but it won't identify in which organ fibrosis is going on, origin of fibrosis. Next, USG can't differentiate between fat and fibrosis. Advise the patient about all the side effects and ask them to consult immediately if any side effects. Like, share and subscribe my channel, The Average Dermodoc. Thank you. Hasta la vista. Desvidania.